Hi, I'm Elisa Ranieri,
Hi, I'm Fred Ellerington.
and we are homeless outreach workers at St. Michael's Hospital located in downtown Toronto. We work on the general internal medicine ward, which is the most common place for people experiencing homelessness to end up if they are admitted to hospital. General internal medicine sees everything from overdoses to the flu, major infection, wounds, hypothermia, and other issues. In 2019, our ward saw approximately 600 people who are homeless.
Our program is called the Navigator Program. It's funded by St. Michael's Hospital Foundation and led by Dr. Stephen Wang, who is a physician and scientist looking at homelessness and health. The team consists of two of us, a part-time coordinator, oversight by Dr. Wang. We work with people who are homeless when they are admitted to the hospital, support while in hospital, and work with them up to 3 months after they are discharged to help them meet their discharge plans. Examples are coffee, talking with shelters and service providers, taking to appointments, negotiating after missing appointments, etc. Currently starting a major evaluation of the program, which will be something to discuss at future conferences.
So in this presentation, we are hoping to talk about common experiences for people experiencing homelessness in hospital, what we know from research that may help keep people out of hospital, and share some of our tips for working with people in and out of the hospital using some case examples.
Let's start by talking about what hospitalization is like for homeless people. Before working in the hospital, we were both community workers. As community workers, we have all been frustrated with hospitals at least some of the time. Communication is key. Equitable treatment is important. Discharge plans that don't seem to make sense and are seemingly no discharge plan at all. And readmission to hospital and declining health despite hospitalizations are ongoing issues. Dr. Wang completed a readmission study with people experiencing homelessness at St. Michael's Hospital before our program started to get the lay of the land. Data was collected in 2017 and 18. There have not been many previous studies on homeless patients and readmissions. This study enrolled people when they were hospitalized, conducted one interview, and then with them during their hospitalization, and they received permission to track their health records after hospitalization to see if they were readmitted. There were 129 patients enrolled in the study. 35 or 27% were readmitted within 90 days of discharge. There were 3 factors associated with lower odds of readmission. 1, having an active case manager. 2, having informal supports like friends or family. 3, when a copy of the discharge plan was sent to a primary care physician who had cared for the patient within the last year. Also, a higher number of medications prescribed at hospital discharge was associated with higher odds of readmission. Other indicators to severity of illness were not associated, so this finding is probably more about organization and medication management. What does this mean for our program and our community workers? We, and most of you, are not doctors. We can't make the discharge plan or determine the number of medications, but we can help make those things happen, especially when we have evidence it will work. We're going to go through 3 case studies where these factors and others were at play and share our strategies for addressing them. I'm going to talk today about a man in his early 60s, a very unique client who was very sick and had extensive hospitalizations and kept coming back onto my caseload. He had severe COPD, which is a long-standing breathing problem, alcohol use, congestive heart failure, and no primary health care, continued to smoke, and was not taking his medications for heart or respiratory conditions. Unfortunately, he was sleeping in a mat in a respite center, so he was on the ground and not getting great rest. Coming into hospital constantly, he had 58 emergency department visits and 66 days in hospital in 2019 alone. In that first year of seeing him, I did a lot of failed housing attempts with him. He went to a rooming house, he went to long-term care, he went to a senior shelter. All of those things failed and he ended up back at the respite center. We had to keep pushing through, trying new things. Medical staff assumed that this is how it was. No way to change his health. Every time he came in, it would be very quickly diagnosed that this was his condition, he needed a few days, and he would be discharged. So we need to sometimes find that patients are labeled as high users and nothing new is tried. During the second year of knowing his patient, he had 23 days in hospital, 11 ED visits, which is a huge reduction. When we look at the difference and the things that made a difference in his life, he was adherent to his medication. I was accompanying him to his appointments. He was seeing a family doctor. I kept working with him over that long period of time, found more appropriate shelters for seniors even when housing didn't work. So other things that we did was request his medication to be put in blister packs. You can ask your pharmacy to do that, or connect to the medical team while in hospital and ask blister pack to be on the prescription. It's easier to take and it's more organized, and you can keep track of how often they are actually taking their medication. So again, we accompanied him to medical appointments at the hospital in the community. We organized community care, coordinated home care to come to the shelter or to where he was staying. His family doctor was early on, and he kept going to see that family doctor regularly.
So I'll be talking about two case studies. The first one is a 62-year-old cis man. He came to the hospital 2 weeks after being released from being incarcerated. In that time, he hadn't been able to keep any food down, and he was diagnosed with inoperable cancer in his esophagus. He had a long history of homelessness and spent a lot of time incarcerated in his life. He had no family or social supports. At the beginning of his hospitalization, he was very aggressive. Some of the things that happened was he punched a security guard, he threw an IV pole at a nurse, and used very abusive language towards staff and other things. He often left the hospital against medical advice. And in the 1 year prior to his admission, he had 24 ED visits and 1 hospital admission. These numbers would have been significantly higher, but he was incarcerated for 4 months out of 12. He did end up staying in the hospital for 3 months, and he worked with me the whole time, and unfortunately passed away in our palliative care unit. Throughout his hospitalization, as time went on, the aggressive incidents dramatically reduced. So I'm going to talk about some of the things that we did with him while his time in hospital. So one of the things that we did was we found out what was driving his aggressive behavior. So we established that he was really concerned about ID that he had lost, glasses that had been lost while he was incarcerated or when he was brought to hospital, and he couldn't actually see. And because he was unable to keep food down, the hospital wasn't giving him any food by mouth, so everything was being fed through a tube. And also, he denied having any hearing impairment, but when you spoke to him, he often had trouble hearing you and couldn't relay any of the information back. So we identified that hearing was a huge barrier. So some of the things that we did is we replaced all of his ID. We got him glasses. We reinstated his WSIB payments, and we obtained a pocket talker for him. A pocket talker is a device to amplify sound that does not require a hearing assessment. So in addition to this pocket talker, we placed a note outside of his door for staff to use as a reminder to use the pocket talker and to speak loud and clearly when communicating with him. We were really upfront about challenges to the staff. So we were able to match him with a nurse and other care people who were more comfortable with his reactions and behavior. We were able to obtain the pocket talker using the Flex Fund from the Navigator project. I met with him daily, and so we were able to build a trusting relationship. So, he couldn't leave the hospital all the time, so I was able to go out and buy the glasses for him, sort of using his money. I was able to go get mail for him at the shelter, which included some of his WSIB checks that he was often leaving the hospital for to go get. So having that consent from him to the shelter to be able to do that, and really having an open dialogue with the hospital staff about what his needs were and how to meet those. The second thing we did was setting up activities that he enjoyed in the hospital to help him stay and be more comfortable. He wanted to get the daily newspaper. He loved crosswords and books. The TV in his room was touchscreen, so we had to arrange for instructions on how to use that. He really wanted a cell phone to be able to communicate to his mother and also just to have some independence. So we helped him purchase a cell phone. And actually, prior to being hospitalized, he hadn't spoken to his mother in 10 years. She lived on the East Coast, so unfortunately, they couldn't have any in-person contact, but it was nice for them to be able to reconnect. The third thing we did was learning about why he was leaving AMA. So, in addition to all of the things that I have already talked about, a major part of that was like engaging with him every day and just listening and asking him about why he was leaving the hospital or things that he needed outside the hospital that would make him more comfortable being in and staying in the hospital. A lot of it was around sorting out his finances, which we already talked about, were things that I was able to help him with, so he doesn't have to leave the hospital. And one of the other things that we did that was really important for him is as his symptoms worsened from the cancer, his pain increased, which, led to a lot of issues. So advocating for better pain management was something that I did regularly, and asking the medicine team for more regular check-ins. And all of this improved pain management, his comfort, irritability, and overall engagement with the care team at the hospital. The last case study is a 38-year-old cis woman. So we'll talk a little bit about her. So in the 2 months prior to her final admission for this health concern, she was admitted 5 times and left against medical advice each time and had 1 ED admission. The issues she was presenting to hospital were for septic arthritis, which is an infection in joint tissue, and an abscess in that same hip joint. This all required IV antibiotics, removal of fluid from her hip and abscess, and a possible hip surgery. Anytime that she left AMA, we were unable to provide any treatment because there just wasn't enough time to complete all the tests. So to help with that, I would go to places she would frequent, like the supervised injection site and the shelter where she was staying, and encourage her to return to hospital or speak to staff that regularly supported her. In the end, she managed to stay in the hospital for 46 days, have her hip surgery, and complete a full course of antibiotics in the final 6th admission. So I'm going to talk about some of the ways that we were able to support this. The patient was a person who uses drugs, so we were able to alert the addiction medicine team when she was on her way to the hospital, and that way they could meet with her right away, so they could immediately start providing support so she was comfortable while in hospital. And in addition to the addiction medicine team meeting with her right away, we also had daily check-ins to make sure that the medications they were providing were making her comfortable and less inclined to leave against medical advice and use street supply. The second thing we did, and we do this for all people that come in that are staying in a shelter, is that we will make sure that their shelter bed is placed on hold. So asking them where they're coming from and calling the shelter right away. This helps put people at ease to staying in the hospital, makes them less nervous about losing their bed and all their belongings. And in addition to putting the shelter bed on hold, we were also having regular conversations with the shelter staff about her status in hospital. One of the things that we did as well for her was that we advocated for a discharge plan that would have the best outcomes for her. So while in hospital post-surgery, she was transferred to another floor that was less familiar with the client's needs. They created a discharge plan that was really unrealistic and would have led to further complications of her hip and infection. She needed IV antibiotics 3 times a day for 6 weeks, and they were expecting the client to be able to go to a community clinic or have a nurse find the client 3 times a day in the community, which would just not have worked for her. So I was able to advocate for her to stay in the hospital to complete this treatment due to her being homeless. And that was successful. And then after discharge, she needed every other day wound care dressings. And also at that time, they were expecting her to go to a clinic or have a nurse come and find her in the community, which the client identified as a huge barrier. And so we were able to use those existing supports that she already had in places where she went regularly, where there was nurses who could do that wound care for her. So that required some coordination of community supports and regular contact with them to make sure that's something they were able to do. And we were also able to use the Flex Fund from the Navigator project to pay for those wound care supplies. Another strategy we used for her was we identified the barriers to leaving AMA. So she often left against medical advice to meet her drug use needs, visit friends in the community, get food that she liked. She really didn't like the food in the hospital, and feeling stigmatized by staff providing care. So we already discussed the addiction medicine team and how important their communication was with the client and with the medicine team to make sure that she was comfortable. And we were using flex funds from the Navigator project to be able to purchase food that she liked. And we educated her on how to update her approved visitors list so her friends and other supports could come into the hospital and visit her instead of her having to leave. And we also supported hospital staff to understand her needs and reasons for actions, which improved her care. So one of the other things that we did for her was that we had regular communication between her hospital, between the hospital and her existing community supports. She had a lot of really great ongoing community supports, and so we were able to share updates with them and provide them with updates from the hospital. But it also helped with, as we discussed, like discharge planning. And when people from the community are regularly checking in, it helps to keep the hospital accountable with their care for people. And the last and one of the most important things we did was that we connected her with a primary care provider in the community for ongoing support post-discharge. And she hadn't had a primary care provider for several years. So this was something that was really important, and she is remaining engaged with them. So in summary, what are the main things we can do to help people who are experiencing homelessness when they're hospitalized and after they leave? Communication and talking. It helps the clients when the community supports and hospital staff are talking. Anything you can do to keep the communication open will be beneficial. Some things to keep in mind are that the hospital is dealing with crisis care, so they may not have the understanding of the client's context that community workers have. So being available to talk and communicating those needs to the hospital is super important. Around leaving against medical advice, it's so important to listen and talk to clients. So why are they leaving the hospital? And what can the hospital and the community supports do to help them stay and finish their treatment course? Sometimes the solutions are really simple, but make a big difference, like getting a daily newspaper. Other things that we can do is we can support clients who have recently been discharged to make sure they are following their new medication practices, accessing ongoing care, and going to their primary care or specialist appointments. Some tips for that are to work with the pharmacy for best methods around medication adherence, going over the discharge plan with your clients and hospital staff, if possible, before they leave, so that you can go over any questions you might have. And if you're not able to do that, know that you can always call the hospital if you have questions about it. It's really important to make connections to primary care and ask the hospital to help facilitate that if they're able to, and support clients to get there. So whether you're working inside the hospital or in the community, building a relationship with a family doctor or a nurse practitioner has been so important in improving health outcomes and reducing hospital admissions. And just around the appointments, providing reminders, getting people to their appointments, helping people retain information and ask those really important questions that sometimes people forget is so important. Another tip is don't give up on clients. We found that, sometimes it's like your 20th attempt that really clicks, and ultimately, this is about building relationships with people, showing up and being consistent. So lastly, if it's at all possible to advocate for your team or organization to have a flex fund, and that's to advocate for small healthcare supports that can often fall through the crack but make like a huge difference. So things like transit or taxis, wound care supplies, prescriptions that aren't covered, and other medical equipment, small things usually. Thank you for coming. As we mentioned briefly at the beginning, we are starting a research study about our project, and hopefully we'll be back in a few years to share more details and the results. So we hope you enjoy the rest of your conference and see you live at the Q&A room.